Good afternoon. I'm so pleased to welcome all of you here this afternoon to this new location, but for one of our most special lectureships, the Laverne Gulman Lectureship in Nursing. And we are especially pleased today because we have the person who is honored by the establishment of that lectureship with us here today, and that is Dr. Laverne Gulman herself. Please. If you, And I hear you have a birthday coming up next week, right? A birthday coming up?
Yes. I left that behind.
Oh, well, you know, considering the alternative, birthdays are good, right?
Oh, yes.
And we are also pleased to have with us today Dr. Billy Brown, who's the former dean of the School of Nursing. So please. And I know we have several retired and former faculty here in the audience and some community members. We just want to welcome you all to join us today. We have several endowed lectureships at the School of Nursing, but I think this is our most special one, without any slight to the others. But it is a very special and unique lectureship, mainly because of the way this lectureship came to be. Back in the, I have to see when this was, 1984, one of our doctoral program graduates, Mary Lou Bond, and I did get a chance to talk to her. She was hoping to be here today, but I think she had to be out of town for another event. Got together with several of her other colleagues who were either recent Ph.D. program graduates or still students at the time, and they each pledged what was a very large sum at that time, and still a large sum today, $500 each, to get this funding drive started. Now, students, recent alums, take notice. This group managed to corral enthusiastically a whole group of current and former graduate students who had all benefited from the work of Laverne Gulman to contribute to this, along with faculty and staff, and I believe the total was something around $26,000 that they raised, and it was then matched by a special fund that the UT system had. This was at the time of our UT centennial, and they had special funds available to match and endow lectureships. So the lectureship started with a $50,000 or $56,000 endowment. Today, that endowment, which you all understand, an endowment is something that we don't spend the principal. It gets to grow over time with additional deposits and the interest, and we just spend some of the interest. That endowment today is worth almost $250,000. And so each year from that endowment, we are able to bring special individuals to our campus. We've already arranged one for the fall as well, who can spend time with our faculty, our students, and present to our community about the work that they have done. So don't forget, when you're called on to participate in great efforts, you never know what they can go on and establish. And really, all of us as students, faculty, alum have benefited from the great gift of that lectureship that has endured over time. I want to tell you a little bit about Dr. Laverne Gulman, our honoree of this lectureship. She received an Associate of Arts degrees from Kilgore College and her nursing diploma from the Scott and White Hospital School of Nursing and a BSM from UTMB, the University of Texas Medical Branch. She completed coursework for her Master's of Science in Education, all the while commuting back and forth from Temple to Austin. I don't know if it was better or worse to commute back then than it is today. And she served as an instructor for Scott and White School of Nursing and later as their education coordinator and associate director. And she was instrumental in creating the baccalaureate program at Mary Hardin Baylor School of Nursing in Belton. And just this year, they have a new building, which I'm happy for them, but sad for us. But anyway, and they, I believe it's the Dean's Conference Room that was endowed in honor of Dr. Gulman at that institution as well. It was a very nice honor for her again. Now, I want you to take out your pens and pencils and correct this mistake in the program. There's a very grievous error It says she earned her Ph.D. from the University of Texas at Arlington. Cross that out. It was Austin. University.
Really glad to have her.
I'm sorry, but I don't think you had a PhD program in 1970. But anyway, she got her PhD in curriculum and instruction from UT Austin, and we absolutely claim her. So even though we share many things with our sister school to the north. Her impressive career then, after she had worked other places in Central Texas, she continued it here at UT Austin, where she was a full professor, assistant dean for curriculum, interim associate dean for academic programs until, I don't know how everyone let you retire, but she finally did. And I was just sharing with her, I remember when I came here as a potential graduate student, very surprised to understand that I had to apply. But that was in March of 1982, and I walked in the building, and she's the first person I met, and things just got better from there. Everything was good. So we are very pleased that we've been able to have these lectureships over the years, and we're most pleased that she could join us again today. So today, it's my pleasure to introduce to you our speaker that has come from afar, Dr. Eun-Shin Nahm. And Dr. Nahm, I became acquainted with her when, quite frankly, I was hunting for some additional expertise in informatics, and a very, very well-known senior person in nursing informatics gave me 3 names, and one of them was Dr. Nahm. And we talked at length on the phone. I learned about her research. I stalked her on the web so I could learn what she was up to. And I just thought it was so interesting and so applicable with our focus on health promotion here in Austin that we thought she would be ideal for our lectureship, and she agreed to come here today. Dr. Nahm holds a BSN from Ewha University in Seoul, Korea, and we have links to that university. It happens to be the world's largest female educational institute. And Susie Kim, who was she their dean? Is that right? Susie was here for I guess a postdoc fellowship with Dean Brown many years ago, and has been very active in Sigma Beta Tau over the years. And I think that Susie and I were inducted into the academy the same year. She has a Master's of Science from the University of Hawaii at Manoa, I think I said that right, and a PhD from the University of Maryland School of Nursing, where she is an associate professor. She's a fellow in the American Academy of Nursing, and she's the program director for nursing informatics at the University of Maryland, which has a very well-known and highly ranked program in that area. Dr. Nahm has focused her research on the use of e-health interventions to promote and manage health of adults over the age of 50 on computer-mediated social support among older adults and on hospital information systems. She's widely published, has more than 35 peer-reviewed journal articles and numerous book chapters. And she's going to present today the findings from her R01 grant that was supported by the National Institute of Nursing Research, which is the theory-based bone health program for midlife women. So please join me in welcoming Dr. Eun-Shin Nahm.
First of all, thank you. Good afternoon. It is my really great honor to present my research at this special Gallman Lectureship at this School of Nursing. And in my academic and research career, I had a few very important mentors. And Susie Kim actually sent me in the United States. And I wouldn't be here today if they didn't help me, and that's the reason I think this lectureship, when Dr. Steiffbergen explained it to me, it really touched my heart, because my mentors is very important to me. And a couple of my mentors became more than mentors, like became mom right now. So, it is my hope always as a teacher. I like the term teacher. In the future, a couple of my students at least would remember me in a way that I remember my my mentors. I think that will be really a great accomplishment as a faculty and as a person. So I think, thank you, and I'm so honored to present our study today. And this wonderful university, and actually this is my second time. And the story, I have to tell you the story. In 2010, there was a conference, the Southern Research Nursing Society conference, and my plan was that as soon as it ended, I was going back to my home, Baltimore. But I couldn't leave the city. Can anybody guess?
No.
I know. So I got stranded at this, Texas, and of course in Baltimore they were really buried with the snow. But here the weather was good, and I had a few colleagues, so I got to know the city a little bit more. So one place that I visited was Lyndon Johnson Library. It's in this campus, right? Yeah. So I thought when I came in, when I enjoyed the library, but at the same time, when I look at this campus, wow, this is a campus. Because in Baltimore, we have a building with nice garden. So it's within the city, several buildings. But here it looks like a campus, so it was not bad. We went to see some nice cowboy hats. So we have some history. So by then, who knew I'm going to come back and give a lecture, because at those, I think I stayed like 3 or 4 days in a hotel, and I was dying to go home. But it's good to be back here. So today, I'm going to talk about this a little bit. First, I would like to talk about the background of my research and practice and education, and then I will move on to our main research project, the currently ongoing project. And then finally, I would like to talk about a little bit of a future direction of our study. So that will be the talk for today. And I think I have about, 45 minutes. Yep. So the background of my research. In my area, as a researcher and as an educator, these 3 areas are always, to me, seamlessly integrated, because I cannot think of one without another. And my research was based from practice and also from the community. Actually, it should go back and forth. My research topic should be based on practice and community, and the findings of our research and education and practice should go back to the community. So community has been always a very important component of my research and career. So from that regard, my research emphasis, I think our dean already explained my research emphasis area. The use of e-health and m-health interventions to promote and to manage the health of older adults. And prior to my faculty position, I served as a systems administrator at the Hopkins Geriatric Center. And at that position, my role was to evaluate healthcare information systems and implement. So currently in my nursing informatics program at the graduate level, I teach senior level nursing informatics, and also I coordinate nursing practicums. So we run a national program for informatics. So I have students all over the state. And at the moment, I have 2 students in Texas. One is in Dallas, and one is in San Antonio. So I got to know the hospitals and what is going on in informatics area in Texas. So I thought that was a small world, because I just communicated with our preceptors. So that's my research emphasis and professional practice. For education, in our program, we have about 120 master's students in the informatics program, and about 13 doctoral students who focused on nursing informatics area. So 5 of them are Ph.D., and about 7 we have DNP students. And in the doctoral program as a teacher, in this semester, I teach grant writing courses. We have excellent doctoral students. I'm sure that you have excellent doctoral students as well. So we kind of live through the pain, writing grants, NRSA, and other grants. But they have been managing it pretty well. So at the Ph.D. program, I teach that class and also give lectures, and I supervise a research practicum and rotation students. And for clinical practice, this is very important. My clinical background is gerontology. Always, somehow, I really loved to take care of older adults as compared to other generations. So I can connect to older adults somehow, but not the pediatric patients. So my heart is always with older adults because I just love to take care of them. And then I think I was a good clinical nurse. I loved it. But when I was taking my master's program, by then I was a foreign student with a lot of difficulties. You know, when you came in, you have to work with different culture and language and other aspects, and I was alone then. And I started my practice first, so went through a lot of difficulties, and then went to the master's program. And when I went to the master's program, I had to learn how to use computers. And I just fell in love with it because computer programs really augmented my abilities, doing things. You know, I can type fast. And then internet, when I learned the internet, really, there was a whole new world out there. You know, especially for culture. I didn't know many aspects of culture, but I was able to find those information in the internet without asking people. And then email, using the email, I was able to communicate with other people. So then I was thinking, I'm going to do, really, this is my area. I'm going to work on this. And I started taking all those computer classes, programming classes and network classes. And then I realized that by just programming systems or programs are not really my cup of tea. You know, I was able to learn it, but it didn't give me really pleasure. So I realized that, you know, for me, you know, I'm a nurse, so I'm going to use technologies to make people's life better. And then I decided to go to the Ph.D. program and ended up to the Maryland. So that's kind of my background. And when I started my Ph.D. program, by the way, the topic of my research, I started with this topic and I still keeping it, you know, using technologies for the adults. So when I started my PhD program, I was told that I will never graduate because we are talking about many, many years ago, right? And all the adults were not using computers then. So I was told there is no funding opportunities, you will never get sample. But you know, when I come to think of it, you know, the evolution is evolution. And the technology evolves, and all the adults thought they should. And I kept on it, but guess what? I was able to conduct my own study with NRSA Pre-Doc Award. So, and I was able to accomplish, and I think I made a good choice to keeping on it. So that's kind of my started. And I truly believe that, you know, at that time when I started my research, there were not many publications about how older adults learn computers or how they respond. So what I did was I went to the community. And my mentor she's a nurse practitioner, Dr. Resnick, and she had a clinic in the CCRC. So I volunteered to be a computer teacher. So I taught older adults who have never learned how to type. You know, I teach them how to use computers. And then I learned how they respond to the computers, and I was convinced that they can use it. So my research started like that. So always from the community, I think. And I wish I had more time so that I can teach older adults more. And believe it or not, my class was very popular. So, you know, I always had a waiting list. And also I taught another group, the older adults in the housing, senior housing area, underserved population. So I was able to compare the responses between two different groups of older adults. And both of them were able to use it. And actually, I got more gratitude from the older adults from the senior housing area. So my research, evolution of my research is that in my research, I combine these three areas: gerontology, informatics, and behavior change. That's kind of my research framework. And then this is kind of a background of my research. Currently, my research is the bone health study. I'm going to share with, the results with you. And this bone health study is based on prior studies, mainly these two R21 studies. The first one is about the hip fracture prevention, focused on calcium-rich diet and also exercise. And then when I started, it was going very well. And after that, I included caregivers, because when I take care of older adults, it's always a teamwork: patients, caregivers, and clinicians. So in this area, in this study, I was able to include the caregivers, and then I learned how they respond to the resource program. And by the time when I finished those two, I was ready to disseminate. You know, I was able to see the efficacy, and I know that we can do it. So now this study is about the dissemination study rather than traditional efficacy study. And when we started this R01 project, initially we worked really hard. Everybody does that. You know, once you get funding, then after that you gotta work. So after 2 to 3 years, you know, my study was going on very well, and I have to think about the future. And what is the future? And I can think about two aspects. You need to add more technology, because technology evolved. And also, as a researcher, when your research is going well, then you need to replicate, right? So that you can use the same approach for different population and different illness conditions. So our team started working on these two projects. One is the mobile devices, and one is aging older adults. So this topic is also based on the community. When we went out, recruit participants, we recognized some issues, health issues in aging nurses. So that's where this pilot study began. So this kind of a chart shows you some evolution, really, pictorially. So from 2003 to 2006, we conducted many preliminary studies supported by training grant and intramural grant. It's about the measurement studies, theory testing, and some developmental study from 2003 and 2006. Then our first R21 started 2006, and second R21 study started 2007. And then by then we kind of know it's going well. So in 2009, we started this dissemination study, which I will share it with you. And currently these two pilot project is going on, and eventually this will feed into our study and then move on to the next level. So Bone Power Program, first, I would like to recognize my research team. I will not read individuals' name, but as you know, that research is a teamwork, isn't it? Nobody can do research by yourself. And fortunately, I have a really great, stable team, and I gotta tell you that some of my co-investigators were my mentors. Now they became my co-investigators. Things change, isn't it? But it's good to have your mentors as a team members, because you can really ask questions and seek guidance. And I have a wonderful web development team, which is like running as like well-oiled machine. And the other component is my doctoral students. They work really hard. And then they do excellent job. So I was fortunate to have wonderful students, group of students. So this is my team. I would like to recognize their hard work. So going to our the R01 study, the aim of the study is to examine the impact of two social cognitive theory-based online health programs on the re-aim outcome dimensions among members of two large online communities. So we are testing two programs. In our previous R2N1 study, we tested a short-term theory-based interventions, and we saw the effectiveness. But that short-term intervention didn't change. We saw the significant changes in self-efficacy outcome expectation or calcium intake, but it didn't really change the behavior, exercise behavior. And in this study, we expanded. So we are testing an 8-week theory-based online bone power program. And then we recognized that, in online studies, we have to think about also the inoculation dose. You have short-term intensive therapy, right? And after that, you can give an inoculation or booster dose. So this second intervention is a long-term intervention that includes short-term intensive program and a 10-month booster intervention. So the booster intervention in online study, we use bi-weekly theory-based e-health newsletters. The newsletter itself is also theory-based. So we use testimonials and we encourage them to set the goals and so forth. So that's what we are currently testing. And some of the background about the dissemination study. Nowadays we talk a lot about dissemination and translation because we do the research. Then what about what happened with the translation or dissemination? So when you think about the bone health, in the past decade there have been significant advances in bone health research, and actually many good studies produced effective measures to improve or maintain bone density. But then the issue is that currently we have about 44 million Americans living with osteoporosis or at high risk for osteoporosis. So there is some issues here. We know that some interventions are working. Then why we are still having this big osteoporosis problem? So and the medical cost too, 22 billion in 2008. So it's pretty high medical cost. And when you think about the fracture, hip fracture or spine fracture, they can make people's life really miserable, and it's deteriorating conditions in addition to cost. So I think that's serious issues. And then the next level at this point, now we know what is working. The next level of study should be dissemination study. So how can we disseminate this evidence-based practice or interventions to the community so that people can incorporate their interventions into their lives? So there are many ways you can do, but in our study, we use the internet. When you think about the internet nowadays, people use internet, right? The internet has become an excellent dissemination medium in every generation nowadays. About 81% of American adults are online users, and even 65 plus, more than half of older adults are using online. And we know that these individuals have a keen interest in health. And you can think about many good websites. Medline Plus, how much information can we get, right? And then Mayo Clinic or even the hospital, Baylor Hospital's website, they have fantastic information and fantastic website. But then, really, do lay persons know where they can go and find information, right? I think that's kind of an issue at the moment. And many studies tested actually online interventions. However, they tend to be short-term, and their protocols are not consistent. So there is we have some challenges in dissemination efforts. So really, do public know where to find credible health information? What do you think? Usually people use how do usually people find information? Google, exactly. They Google it. But they could have gone to National Library of Medicine, Medline Plus, or the MayoClinic.gov or WebMD. There are some nice, really helpful sites, but just the dissemination piece is difficult. And then people start using the intervention, smoking cessation or obesity management, but do we know what is the optimal way of delivering the intervention, right? You can deliver the intervention for 10 months or 8 months, or the dose. How much dose will you give per week, and how to make sure that the people is getting the intervention. Even though you push out the intervention, they may not getting it. So there are a lot of opportunities exist to improve dissemination strategies in this online intervention studies. So in our study, the dissemination emphasized a mechanism that will package and deliver resources to the target population so that they can make behavior changes. People use the dissemination term very loosely, disseminate things, right? But as a researcher and as a clinician, the dissemination means it's go out there and we make changes. Then how to package and deliver the online intervention? You think about the website. You can develop website in any way you want, right? You can make it really pretty. You can incorporate all the whistles and bells and whistles. But then, how do you know that it's going to work? So in our study, we use theory-based approach. In behavior intervention or behavior change science, there are certain theories. So when we develop our web intervention, we use the theory-based approach. So the theory will guide us what kind of information we need to put on the website, and also how we deliver that intervention to our participants. And then when you think about the dissemination study, it's not just a simple effectiveness study. In effectiveness study, you measure the efficacy, right? Efficacy of the outcomes and so forth. But in the dissemination study, we can think about very large populations. So what kind of outcomes can you measure? So we use VAIM framework. Are you familiar with the VAIM framework? No? Okay, that's good. So I can kind of explain this a little bit. But VAIM framework is the dissemination study framework, and I use them for outcome assessment. And the next slide, there is an information about the VAIM framework, so we will learn about it. But let's look at the social cognitive theory. And many nurses are familiar with social cognitive theory, right? So we chose this theory because the concepts included in this theory, goal setting, motivation, outcome expectation, or self-efficacy are consistent with our philosophy of research. Because in our behavior research, we try to motivate people to make their life better. And then when you think about this self-efficacy, it really helped me how to develop my website. It gives me instruction that I should deliver this self-mastery experience. If my participants use our program, they should have some sort of this experience, right? And then vicarious experience, verbal persuasion, and make physiological and emotional states better. So that's the way how we use theory to develop and to deliver our intervention. In terms of the VAIM framework, by the way, if you have any questions, you can ask me questions along the way. We can make it a little bit interactive. It's late at night, late in the afternoon, so I know that you are tired. So VAIM framework, it's reach, effectiveness, adoption, implementation, and maintenance. So this effectiveness is traditional sense of outcome study in a randomized control trial. But in the VAIM dissemination study, the other dimensions is also important. How many people do we really reach? What is the impact on those individuals? And how do they adopt? and how do they implement the study, implement the intervention, and how do they really maintain the sustainability become an issue? Important aspect. So the beauty of this dissemination framework is that it conceptualizes the impact of an intervention beyond the assessment of effectiveness. So in our online study, it perfectly makes sense. So we chose this outcome framework. So this kind of summarizes how we applied our REAIM outcome assessment dimension into our study. So reach, the number of individuals we reached, because at the end of the study, even the control group will get the CD-ROM of the entire intervention. So it means that we did something for their health. And effectiveness, this one I would like to share with you today. And adoption is a little bit different. For example, if Kaiser Permanente is implementing diabetes protocol in like 100 physicians' office, then they may be able to see adoption rate, what percentage of offices adopt that protocols. But in our study, it was not really relevant. But implementation and maintenance, that piece we need to evaluate at the end of our 18-month trial. So these are coming up. So this is the framework of the outcome assessment. As you can see, we're not just looking at effectiveness of the study. So the method, our current study is a 3-arm randomized controlled trial with 5 observations. We collected data at baseline, 8 weeks, 6 months, 12 months, and 18 months. And the data collection method is online surveys. In our study, the entire study is online. We don't see participants, and participants are from all over the nation. However, we do communicate with them. When they sign up for our study, then first our project manager contact them via phone, and we kind of go over several aspects, so that we make sure that this is the real person and the person is committed to our study for 18 months. And for intervention, I explained 2 interventions, and then for control group, we used no intervention control. But at the end of the study, they received the CD-ROM that includes all the intervention material, so they get some intervention later. So this is kind of outcomes. So for today, I will focus on these. And as I mentioned before, the study is still ongoing. We just completed 18 months data, so we are still need to do a lot of data analysis, and those will be coming later part. So these 2 tables, the following 2 tables summarize the psychometric aspect of measures. However, not to bore you, I will skip those detailed information, but if you have any interest in any scales, please let me know after the talk. I will be happy to answer any of your questions. So, and then for setting, we recruited our participants from 2 online communities. One is My Health Yvette. Have you heard about My Health Yvette? It's an e-health portal that is used by veterans and their caregivers. It is a really large, well-established program. And they have several 100,000 of registrants, because they have to use it. They use it for PHR or to make the e-prescription and make appointment. And as you can see, our veterans are all over the nation and all over the globe. So My Health Yvette is very well developed e-health portal. And SeniorNet is one of the largest online community for older adults. So I was fortunate to have such wonderful communities. I have pleasure to work with those communities. But when you conduct online studies, those communities are also communities. In the real setting, you work with the communities, right, or organizations to get your sample. The same thing applies. It's better to work with a really good community. For example, when I say older adults, people may think that 65 or older, but our focus is prevention, so the age cutoff is 50 and older. And of course, they have to they have to be able to read and write English and have access to the internet, and they should be able to use the internet on their own. So that's kind of sample criteria. For recruitment, we were actually surprised by the responses. We were able to recruit 866 participants within 7 months. And we were really pleased about that because we budgeted 9 months. But we had to cut the recruitment period because 800, it was too many numbers to manage. So the mean age was 63, so pretty older adult group. And because we were using social cognitive theory, we used a small group approach, meaning that when we had about 60 participants in the waiting list, then we randomized them into 3 groups, and those groups started the intervention together as a group. So as you can see, we ended up having a lot of groups, 48 groups and 32 separate website intervention. So the way how we manage it, so these are each individual website. Each group had their own website. So when they log in, they see only one, their website. So that way, I think people have more collegial relationship. When they do discussion board, each small group is better. And for web platform, for our previous small studies, we just use the web pages. But since we are handling so many groups, we had to add another structure, which is online learning management program. So we use the Blackboard. And I know that many of you use Blackboard, right? So when you think about the Blackboard, that kind of complicated, complex Blackboard page, but we just stripped off all those bells and whistles. When you look at the Blackboard, it looks like plain web page. You can do that. You can change the template, or you can change the style sheet. So we were able to do that. And for the programming component, the major aspect was the learning modules and discussion board, ask the experts. The good thing is that when you have a strong team, we can use the team members, so they can, our participants can submit questions, and then we were able to answer their questions because our team, we had a pharmacist, geriatrician, nurse practitioners, and so forth. So we also developed our video lectures. We kind of utilized our own investigators. They gave lectures, and we taped them. And virtual library, and we have toolkit. Along the way, it has been going on for many years. So we have a large collection of the multimedia program and resources. So we were able to establish the virtual libraries and toolkit. Toolkit means that they can go there and click the button and use something. It could be diary, it could be tracking form, or it could be videotape that shows how to exercise. And then the newsletters, we will see some of the examples later. So this is the login site. If they log in, they will see their own group. But as you can see, we know that some of our older adults are not really familiar with the structured web component, although they use the Google or Yahoo. But online learning system is a little bit different. So we try to give a lot of the instructions. So this is kind of first page, and it looks busy, but we try to explain things. And the good thing is that if they don't want to read, they can just watch the video clip. So using the Captivate, we developed a small, short video component that explains the entire study. So it took it took about 3 minutes. So that because when you conduct online studies, we are not there. Participants, if they have questions, they have to call help desk. But by using this audio-visual materials, we can really kind of communicate with them. And for online learning modules, we deployed, using this online learning management program, we deployed intervention per weekly. So we didn't give them all at once because it's too much. So we deploy the modules per week and discussion board per week. So every week they review the modules and then do the discussion board. And this is kind of the modules that we have. Originally, we were going to focus on the bone health program, like calcium, vitamin D, and falls, and physical activity and exercise. But then our geriatrician strongly felt that they need to learn about the drinking and smoking, and then how those components affect the bone. So we developed those modules. So this is kind of all in our current website. And this was kind of interesting because we were using the social cognitive theory, the goal setting is very important. They need to set the goal before they start our intervention, and then see, follow up on it. So at baseline, we asked them to set their goals for calcium intake and exercise and other goals if they have at the baseline without intervention, right? And then for the intervention group, after 1 week, after the group reviewed overview of bone health, we asked them to resubmit their goals. If they want to change, and they can change. So it was a qualitative analysis, but we see so differences. For example, at baseline, they would say that my goal for calcium, I will drink more milk. Would say for exercise, I will just exercise more. I will walk more. But after 1 week, after the review of the bone health program, they can be very specific. For example, I will drink milk with breakfast and lunch, and then I will take calcium supplement. And many older adults have lactose intolerance. Then they kind of identified what kind of mechanism they can use to overcome their lactose intolerance. So this one was kind of rewarding experience because you can see the results right away. That's one of the beauty of the online study. Sometimes you can see the results. And also people would say that in online studies, because we don't see patients, we are not connected with them. But that's not so true. If you have really good, well-running groups, then you can get all those comments. We don't ask them, but they just send you an email about what is good and what needs to be corrected, or sometimes very humbling experience. What kind of difficulties they have and how the program helped. So every online study I conducted, I have learned so much from their discussion board and from their online comment, I think. So I like the discussion board because I can really hear what they are saying and so forth. So these are the online learning modules, and this is kind of the way how we programmed. For example, Dr. Berantoni, I have 10 minutes, right? 10 minutes? Okay. Dr. Berantoni really wanted to, she's our investigator, but she really wanted to explain how the DEXA scan works. So what we did was we went to her clinic and then we videotaped her. And she also wanted to teach like FRAX, how to use FRAX to patients and caregivers. So she was doing the teaching and we videotaped them. So we put them in our module. And some of the components, and this is the discussion board. So we know that older adults are not familiar with this type of discussion board, so we try to make it really, really simple. So they are not going to see every discussion board at one time because we deploy each per week. So when they look at this discussion board, we kind of give you instruction. Click the link to the left to join the discussion board. So this discussion, we have the threads of the discussion board toolkit, and this is the Ask the Expert. They can they can submit the questions, and video expert video libraries. All of the investigators are from our team. So it was a good dissemination opportunity because our investigators were able to disseminate what they found from their research. And this is the Bone Power eHealth newsletters. And this newsletter is not just static, because we try to incorporate more interactive. If they click on it, they were able to watch the video, or they have some sort of tool. We gave recipes. They loved recipes, bi-weekly recipes. And one important component was about the testimonial. Each group members, if they have some important thing to share, they were able to share in this newsletter. And we asked them if they have anything to share, they can send it to us. And many individuals did, and we are grateful. So for the procedures, when we have approximately 60 participants, then we randomize them. And after that, they completed the baseline first. We gave 1 week, and after the completion of the baseline, we randomized them into 3 groups. And they started the intervention. So if they belong to Bone Power group, they just did 8-week intervention. And if they belong to Bone Power Plus group, then they complete the 8-week, and then they continue receiving e-newsletters for 10 more months. So we measure the outcomes at 8 weeks, 6 months, 12, and then 18 months to see the sustainability of the intervention. So we still need to work on this 18 months outcome. So for control groups, we gave the CD-ROM, but it was a really learning experience to convert the entire website into CD-ROM because of the formats, and nowadays the online protocols change. So we have learned a lot from this tool as well. And this table shows you the plan, the project plan, how the milestones, how we ran the teams. So this is the three groups, each team. So it was interesting, but it ran pretty well. And in terms of it is still ongoing. In terms of the attrition, we are really pleased about the attrition rate. And 8 week, it was 18.6%, but 8 week program was quite intense. Every week they have to read and then did a discussion board. So among 866 participants, 18.6%, it seems to be okay in terms of online study. But when we move along 6 months, 12 months, and 18 months, we were pleased about the retention rate, because we pretty much kept the same individuals. And because this is an online study, we have tons of qualitative data. When you think about the discussion board, and then we have the goal attainment study survey, ask the experts, and then comments from the participants. So our diligent doctoral students, 2 of them, they are working on this cleaning the qualitative data using en vivo program. It was a good experience for our students as well, because they can kind of become expert in using en vivo, which I'm working as well. So 3 of us kind of diligently working on the discussion board at this point. So tons of data that we can analyze. So the data analysis methods, the descriptive statistics, and the mainly linear mixed model, logistic mixed model, and then GEE when you have zero inflated data. For the findings, okay, just briefly. So the average age is 63 we had, and more than half of the participants were male because of the VA participants. As you can see, 80% of veterans are male. So we have more male, and white Caucasian dominant, and with high education. Still we see the trend in online study, more affluent individuals. And for the chronic illnesses, more than half of participants reported high blood pressure, which is consistent with the older adults. But depression is a little bit unusual, like 37.4. But we need to do more analysis. But I think that this is from the VA veterans, and we went through the Iraq wars and everything, right? We were in a kind of a difficult situation, and so the depression is, we need to do more study. For the osteoporosis rate, it's pretty much same as in other groups. So for the computer knowledge, they were quite high level. They had quite high level computers in their age group when we asked. Of course, this is a self-report. And 83% of participants said that they have competent to expert computer knowledge when they compared to their age group. We are talking about 63 years old and sometimes we had 9 years old or plus. For e-health literacy, we use e-heal developed by Norman and Skinner, and the range is 8 to 40. The e-health literacy was about 30. Okay, so let's just look at the 4 waves of data outcomes. I will show you the mean score changes, and then I will just briefly mention that hypothesis testing. So for the knowledge, we measured at 8 weeks and then 18 months, because knowledge, we want to see the right after intensive intervention, and then the retention at 18 months. So as you can see, there is the red is the plus group, and then the blue is the bone health group, and then this black is the control group. As you can see, very sharp increase for the intervention group. Of course, both groups used the 8-week intervention. So we see significantly different mean changes in between intervention and control group, which is good. And then this is calcium intake self-efficacy. I think you can also see the sharp increase at 8 weeks, much more increase than control group. But then at 8 weeks, after the intensive therapy, the scores decreased a little bit. And then after that, it got plateaued. So outcome expectation is high peak at 8 weeks, and then it kind of stayed there, because outcome expectation after the 8 weeks of learning, they know that what kind of outcomes they will get from the behavior. So this is a kind of logical graph. And then calcium intake, sharp increase and then decreased after the intensive therapy, and then goes up a little bit, both groups. And then this control group, we are kind of trying to figure out how did it happen. So it needs more investigation about peak and then drop. So that one needs to be worked on. And this is the exercise. Actually, I was pleased about this exercise graph. Before, with a 2-week intervention in our prior R2N1 study, we didn't see the improvement in exercise. But now, with the 8-week intervention, we see sharp increase in exercise. And for the plus group, it decreased a little bit, but a little bit of decrease. But as compared to the bone health group that didn't have inoculation dose, they drop sharply here. And I'm not sure how it's going to fan out in the 18 months yet, because we didn't analyze them. So it'll be interesting to see, we put all the 5 waves data and then see the slope. At the moment, I'm presenting the mean changes, but later on, when we have all the data, we will compare the slope so that we can see the changes. So far is this one more aspect is the fall rate. It is normalized per month. So we didn't see the significant difference between groups, but they tend to decrease. So for the hypothesis testing, the hypothesis one that we analyze is that we hypothesize that at the end of 8-week intervention, the bone power group participants will exhibit significantly greater improvement than the control group in those outcome variables. And this is the summary of the effect size and then significance testing. So we were very pleased about the results. So we see the improvement, all the outcome variables, but the e-health literacy. But we have some explanation about the e-health literacy. And in terms of the effect size, we see higher effect in calcium knowledge, the knowledge aspect or self-efficacy, and a little bit lower effect in the exercise. So in the hypothesis 2 we tested was that at the end of the 12 months, both bone power plus group and the bone power group will exhibit significantly greater improvement than control group in those areas. But then when we compare the bone power group, the group that didn't use the inoculation dose, and control group, the 8-week intervention, the influence of the 8-week intervention kind of faded out by the time 12 months, except the calcium outcome expectation. And then the bone power plus group, that group had inoculation booster dose, and with the control group, these results were kind of significant exercise. So it means that the well, we need to do more testing, of course, but the results show that the inoculation booster was effective to maintain the exercise change. So that was kind of encouraging to us. And a lot of data is coming, but I would like to share 2 quotes with you today. I will just, maybe you can read. I have learned something new from each module and find myself looking forward to the next week's material. The information has given me the tools I need to evaluate my diet and exercise. And I'm touched by this word. The best of all, modules have motivated me to try harder. And they say, as I age, everything has become more difficult, keeping weight from increasing too much, dealing with aches and pains. So this intervention, we felt like we did something good. So that made my day. When sometimes our participants sent us these emails, then it gives us really great pleasure. I mean, we do research to make others' life better, and in online studies, you can get those comments. So I shared some of quotes with my investigators, and so that they feel better. And this one is also, it expressed something. Since joining the Bone Power program, the number of hints received have helped me feel better, adjusting my diet and more exercise, weather permitting. But the important thing is that when they said that the program helped them to sleep better, or to reflect their health behaviors, it really meant a lot to me. It gives me a really great pleasure. So ongoing and future analysis, of course, 18 months data need to be analyzed, and the re-aim data needs to be analyzed, qualitative data. And also we are thinking about many interesting subgroup analysis. So for the discussion, so far, the social cognitive theory-based online interventions can be effective method to disseminate the evidence-based bone health interventions for community-dwelling older adults. They can use them, they can